Bruce McGibbon. I'm a radiation oncologist for Yale at the Smilow Greenwich site, and very happy that everyone can join us tonight for these great talks on skin cancer. We're joined tonight by Dr. Connors and Dr. Kahn, and everyone will introduce themselves, and at the end we'll be able to do a Q&A. If you have any questions, feel free to type them into the chat, and we'll address them at the end. So first up is Dr. Connors.
Hello, I'm Dr. Richard Connors. I'm a dermatologist in Greenwich. I did my training at my basic dermatology training at New York Hospital and Cornell. And then I did a year's fellowship at the NYU Medical Center in skin pathology. I'm certified in both general dermatology and dermatopathology. I have practiced in this area for, I'm amazed to say, for 44 years. I did 2 years with one of my teachers from New York Hospital at Stanford, and I've been in Greenwich for 42 years. I'm not as old as you might think. I kid people and say I was a child prodigy, and I graduated from medical school at age 12. But I've been doing dermatology for a long time here, and it's highly relevant that we should talk about skin cancer. Nationwide, it certainly is prevalent. It's more common, it's more numerous than all of the cancers combined. But I think that's especially true for this particular area. I talk occasionally to the Greenwich Retired Men's Association. I last did it about 5 years ago. I consulted the Connecticut Tumor Registry to see what the incidence the year before of melanoma in Greenwich was, and it was remarkably higher than it was at that same time in Queensland, Australia, which has the highest incidence of melanoma in the world. So most skin cancer are not melanoma. Most are easily treated, but it's important to find them and treat them early and prevent as much damage by them as you can. The question becomes, who gets skin cancer? Well, anyone can get skin cancer, but the most likely candidate is a fair-skinned person who sunburns readily. Okay, the more easily you sunburn, the more apt you are to develop skin cancer. So we'll run a series of slides here. This repeats what I've just said. And again, it's a very, very common cancer. The fair-skinned individual, the blonde, the redhead, people with lots of moles are more apt to develop melanoma. People with unusual shaped or darker moles may develop melanoma. In addition, people with a family history of skin cancer are certainly more at risk. Those people who have had lots of sun, blistering sunburns, people who have been to tanning beds too much, immunosuppressed people, people with blood malignancies, or especially organ transplants, are very prone to skin cancer. So it's a wide-ranging problem in a wide-ranging population who are exposed to that likelihood. Again, when detected early, as we say here, it's very, very treatable. The general advice is an old skin spot that's changing, particularly in size, color, shape, or elevation, or a new spot on the skin that's growing perceptibly. Those are the warning signs of skin cancer. And the unique aspect of skin cancer, of course, is unlike any other cancer, it's readily available. It's on the skin. It can be seen. It can be palpated. So people on their own do well, as we'll touch on later, to do their own skin exams. The ultimate diagnosis procedure for skin cancer is a skin biopsy. Now, we call it skin cancer, but it's overwhelmingly epidermal cancer. The epidermis, remember from high school biology, is the outer layer of the skin, and that's the interface with the world. And it's the epidermis that's hit particularly by the ultraviolet segment of the sun. And that's what dismantles or disrupts rather the DNA of these rapidly producing epidermal cells. So the lowest layer of the epidermis is the basal layer. The middle layer is a squamous melanocyte, which resides in the basal layer, is Those are the main skin cancers. There's a much less common one called Merkel cell, which we'll touch on later. An aspect of skin cancer clinically is that there's no single predictable presentation. Basal, squamous, melanoma, each has its own variety. Each can have a multiplicity of presentations. Basal cell in particular, prototypically, it's an elevated spot on the skin that crusts or bleeds easily, but sometimes it's just a whitish spot on the skin. Sometimes it's simply an innocuous looking red spot on the skin. Sometimes basal cell is even pigmented and looks like a mole. So one has to understand the multiplicity of presentations. Squamous cell, the second most common skin cancer, often presents as just a skin-colored thickening or nodule on the skin that may present and grow rapidly. It may seem almost like an inflamed cyst. Other times it's indolent and grows slowly. Like basal cell, it may ulcerate and crust and scab. But it does grow. All of these things are malignant, and their essential feature is growth, uninhibited growth. So untreated, they get bigger, they get deeper. Now, the last of the most common skin cancers, of course, is the most worrisome. I see literally 100 basal and squamous for one melanoma. I keep track of all my biopsies. And if arbitrarily I go through them, pick 100 consecutive skin cancer positive biopsies, 75 to 80 will be basal. That's how dominant in incidence basal is. 20 to 25% will be squamous cell, 1 to 2% will be melanoma. So much less common and certainly potentially very serious. However, even melanoma, for many of them, there's a period where they're just on the surface and very curable. And that's why you're looking at your own skin, having a skin doctor look at you periodically is desirable. With melanoma, there's been a mnemonic we've used for years, A, B, C, D, E, to highlight the differences clinically between your typical mole and typical melanoma. Your typical mole is orderly, has a regular border, pretty uniform color, pretty symmetrical in its division, one half like the other half. Melanomas are typically, or often at least, disorderly. And we have this A, B, C, D, E mnemonic. A is asymmetry, one half of the spot different as here from the other half of the spot, by its color, by its shape, by its size. The border, again, mole, smooth, regular, often with melanoma, notched, irregular. The color, ABC, the color in melanomas is often irregular, varied, I should say, brown, gray, white, black, where usually moles are pretty uniform in color. D, the next criterion, is the diameter. It's not a very, it's not a universal one, but your usual melanoma, by the time it's diagnosable at least 6 millimeters in diameter, which is about the width of the eraser on the head of a pencil. Benign things can be that wide. Some melanomas, of course, are smaller, but the bigger the brown pigmented lesion, the more you should pay heed to it. The last of the mnemonic is E, meaning evolving or changing. Melanomas, at least 80% begin as melanoma. Most don't begin from antecedent mold. Early on, they look like a mole. They're small, they're dark, but they slowly, steadily spread out like an oil spill and end up with a width much more than they began with. So A, B, C, D, E are a good guide as to how to evaluate pigmented skin spots. The fourth skin cancer, considerably less common than the other three, but getting more and more common, is Merkel cell carcinoma, which originates actually in the dermis. The Merkel cell is a neuroendocrine cell involved in the transmission of light touch. And the typical Merkel cell cancer is on the sun-damaged skin of a senior citizen Caucasian, often a man, but women certainly can get it, but it grows rapidly. It's typically a bright red or dark red nodule that comes up quickly and is, in a matter of days or weeks, it's getting bigger. And that should get you right to either a doctor or a dermatologist. Again, that's much less common than the other three, but important. What can you do to limit damage that a skin cancer might do? Again, your own skin exam, self-exam. We'll get to that more particularly after this, but I think going to a dermatologist once a year for a skin exam is an inexpensive bit of preventative medicine. But on your own, if you see something that seems different, growing, itch, bleeding. I have a sister-in-law, I'll give you an anecdote, but I was a first-year resident at New York Hospital. It was Christmas time. She presented me with a mole on her right arm that was itchy. And I knew that wasn't good. I was still young in my career, but I said, get that thing off. And it turned out to be a melanoma. So it's an uncommon presentation of skin cancer, but it can be. So you should protect your skin, try not to sunburn. Most of all, I never say no sun, I say no sunburns. A little bit of sun, particularly if you're darker in color, I can't object to. There are good things about sun, particularly vitamin D. There are no good things about tanning booths. They are awful. They should be renamed wrinkle machines. They not only increase skin cancer, particularly young women, but they age the skin very quickly. So here's a guide to skin self-exam from the American Academy of Dermatology. I think we have a skin cancer. It's just on your own, and we'll be able to send you, if you want, these from both the Academy of Dermatology and the Skin Cancer Foundation, this sort of a guide. But you can examine on your own. I urge people once a month, do your own skin checks. And this is a guide to doing it. You don't have to be a professor of dermatology at Harvard to be able to recognize something new or different on your skin. It helps certainly if you have a partner to look particularly at your back. But do these exams once a month. I urge people the 15th of the month, take 2 minutes and do a skin exam. Is there something new, something changing, something you don't recognize? Okay. The most common place, for instance, men get melanoma is the upper back, and they can't see it readily. For women, the front of the lower legs is the most common place, although neither one represents 30% of their locations, but particularly with the back for women is also an important place for melanoma. So do check one another's backs at home. In terms of prevention and sun safety, avoid the worst of the suns, 10 o'clock till 2 in the morning till 2 in the afternoon. Clothing, big hats. My patients kid me, I'm always telling them, get a big hat. Skin cancer on the ear is almost uniquely among men. Women inadvertently protect their ears with their long hair. But everyone should wear a big hat that protects ears and face. Sunglasses, of course. Sunscreens, they should be broad spectrum, water resistant, and at least a 30 SPF. And don't forget, even on a cloudy day, you certainly can get sunburned. And reapply it every couple of hours. Succinctly, in the realm of sunscreens, I think the evidence more and more favors, for a variety of reasons, using the inorganic sunscreens, which are the zinc and titanium dioxide sunscreens. But that is another topic for discussion. But I would favor that type of sunscreen. And they're more cosmetically acceptable. You're not as white when you use them. They've broken the particles down so that you're less white. Yeah, and don't forget the reflection from the water, from sand at the beach, and from snow. The worst sunburns I've seen have been 17-year-old skiing at Vail at 5,000 or 6,000 feet with snow, terrible amounts of ultraviolet on their face. Now the skiing goggles and the helmets protects a lot of that, but the worst sunburns can be out there skiing. And whatever you do, don't use tanning beds. Again, they should be renamed wrinkle machines. There has been an uptick over the last 20 years or so in skin cancer, melanoma, squamous cell in young women in America, undoubtedly because of they're the primary users of tanning beds. And these are two references. The first is from the American Academy of Dermatology, spotskincancer.org. They have excellent material, excellent pamphlets on all the different skin cancers. The same is true for the store.skincancer.org, that's from the Skin Cancer Foundation. Wonderful material, very inexpensive, and it details more of the clinical presentations of the various skin cancers. Thank you for your time.
That's great, Dr. Connors. I'm gonna just talk next. Let me just pull up my slides. Okay. So my name is, let me put it on here. So my name is Sajid Kahn. I'm one of the surgical oncologists at Yale. I'm one of three surgeons at Yale that take care of melanoma patients. There's myself, there's Dr. Olino, and there's Dr. Clune. And we see patients currently in the Shoreline, in New Haven, in Trumbull, in our clinics, and we provide care of patients throughout the state of Connecticut. We are also working closely with some of the excellent surgeons that you have at Greenwich Hospital, such as Dr. Petrotis, and we hope to have a bit of more of a presence for our surgical oncology group at that time in that location as well too. So what I'm going to talk to you about from my perspective is from a surgical oncologist. So Dr. Connors gave an excellent talk about from a dermatology perspective on skin cancer. Mine is going to be a little bit more focused on melanoma because many patients with skin cancers don't see us. They see dermatologists such as Dr. Connors who can handle things within their office. Oftentimes dermatologists such as Dr. Connors and other dermatologists throughout the region, when they see a patient with a melanoma diagnosis, they'll have the patient see one of us. So this is just going to be a very basic talk going over some of that from our perspective. So this is a general slide that shows that cancer is obviously a big problem in America. So in 2020, nearly 2 million people were diagnosed with cancer altogether. I'm sure just that everyone in this audience has been affected somewhat with cancer, whether it's personally or with a friend or a family. Unfortunately, we still have a lot to do with our battle against cancer. Over 500,000 people died in 2020 due to cancer. And cancer is not just a problem nationally, it's a problem locally here in Connecticut. Just in our small state here, over 20,000 people were diagnosed with cancer and 6,300 people died of cancer specifically. This is a slide that you may see in other talks if you haven't seen this already. And this is a slide that shows the top 10 cancers diagnosed in the United States in men and in women. You can see that the leading cause of cancer, the leading diagnosed cancer in America for men is prostate cancer and in women is breast cancer. The purpose of this talk is melanoma, and you see melanoma does make the top 10 list for both males and females, accounting for 60,000 patients in men and 40,000 cases in women. And this is some of this is a little bit of a recap of Dr. Connor's night presentation, but 3.5 million Americans, probably even higher than that, were diagnosed with a non-melanoma skin cancer, such as basal cell or squamous cell carcinoma. The Merkel cells, like Dr. Connor said, are quite rare, and deaths related to these types of skin cancers are uncommon. And the number of individuals diagnosed with melanoma is nearly 100,000, and it depends on whose statistics you're looking at. But the American Cancer Society last year reported 100,000 individuals diagnosed with melanoma and 6,800 cancer-related deaths from melanoma. They also document, per the NCCN and per the American Cancer Society, that the incidence is rising. There's some controversy to that, but the incidence is rising according to these sources. And the lifetime risk of developing melanoma is 1 in 34 for females and 1 in 53 for males. So it's not an uncommon problem. So So UV light exposure is a major etiologic factor, and like again, these are not. This doesn't even sum it up as well as Dr. Connor summed it up. But sunburns early in life. These are some questions that we ask our patients in the clinic, in our surgical oncology clinic. I always ask them about sunburns, particularly blistering sunburns, which is the risk factor for development of melanoma. Tanning beds, which are obviously they're very dangerous, kind of like cigarettes is the analogy I use them to oftentimes. Personal history of melanoma or other skin cancers, a family history of melanoma. There are less common things such as dysplastic nevus syndrome, xeroderma pigmentosa, some genetic mutations and radiation exposure as a child, but those latter ones are much less common. So the key to a good outcome for melanoma often is an early diagnosis, as is the deal with other types of cancers, solid tumor malignancies, and prevention. And first thing is to avoid UV radiation exposure, and this is particularly important for fair-skinned individuals. Technically, just being in a building, being indoors is the way to avoid the sun. Obviously, that's not practical in the United States, but so if you are out and about, use protective clothing, and then sunscreen SPF 30 or higher is what we counsel our patients as well too. So prevention, the best you can. And screening, I couldn't have summarized this better than Dr. Connors, but he also, just to reinforce, talked about self-examinations. After we see our patients in our surgical oncology clinic, that we make sure the patients have long-term surveillance with their local dermatologist for total body checks is what we counsel them on. And we also plug patients into our melanoma oncology program. And that can involve a medical oncologist or a surgical oncologist that follows along. But the key for a certain period of time, but the key thing we tell our patients is you need to see your dermatologist for life, for total body checks. And there are some particular scenarios where patients may need some screening a little bit sooner than that. So these are, we look at the same things as the surgical oncologist, and our eyes are not as good as the dermatologist eyes, such as Dr. Connors and some of the other dermatologists, because we oftentimes will see patients with a cancer diagnosis, and we are working on patients, taking care of patients once that diagnosis is made. But these are questions we ask our patients just during their visit to our surgical oncology clinic. We ask them if they have any recollection of the tumor or the lesion for asymmetry, borders being irregular, the color not being the same or uniform throughout, the diameter larger than a pencil eraser, and has the skin lesion evolved over the course of time. And these are just some simple examples of an asymmetric melanoma with another one with an irregular border. You can see stitches there in the middle from a biopsy that was performed. Color variation, meaning the color is not the same throughout the entire skin lesion. Diameter larger than a pencil eraser. So those are, and then the evolution that I didn't show any pictures on. So now, so let's say someone that is diagnosed with melanoma, they see the dermatologist performs a biopsy. And, at that point, that's such a critical point in the workup and the whole management of this patient. So, we work very closely with the dermatologist. We have the dermatologist office will fax us or send us over the biopsy result after they've performed the biopsy, and we pay attention to this. This slide just sums up how our surgical management is for the primary tumor. We have patients that have presented with melanoma in situ, and that's melanoma that has not invaded into the deeper layers of the skin, which is a favorable thing because there's no lymphatics in that superficial layer of the skin. Thus, there's no risk for lymphatic spread. So, for melanoma in situ, we tend to excise margins of 5 to 8 millimeters around the site of the tumor. And I have a picture for you. I'll show you a little bit later about what that means. If melanomas are less than 1 millimeter in thickness, and this is a vertical thickness, so it's if a patient has a melanoma that's less than 1 millimeter in thickness, we perform an excisional wide margin resection of 1 centimeter circumferentially. And I'll show you, it's not technically circumferential. I tend to take an ellipse. If patients have a melanoma 1 to 2 millimeters in thickness, we perform a wide margin resection with 1 to 2 centimeter margins. If patients have a melanoma that's 2 to 4 millimeters in Breslow thickness, we take margins of 2 centimeters. And if patients have greater than 4 millimeter Breslow thick, there's not great data to support what appropriate margins are, but we tend to take a little bit more than 2 centimeters. And particularly if I see someone with some other adverse features, such as ulceration or a high mitotic rate, I tend to sometimes even get 3 centimeters in those scenarios if I didn't do a PET scan ahead of time. But this is basically the margins that we aim for these wide excisions. And you know, in our clinic, we draw out a cartoon, we draw it on a piece of paper, exactly what we do to scale. And you know, the patient's natural reaction is always a little bit of surprise over how wide the margin, how much skin needs to be excised in order to provide a good oncologic margin. And our goal is to provide a good cancer operation and to provide so the patients have a good immediate outcome, but just as importantly, good long-term outcome as well too. And of course, our scars look very nice too, but at the end of the day, we never want to compromise the cancer outcome. Another thing that comes up with sentinel lymph, so I wouldn't read all this, but I'll give you some of the highlights. So another natural question with sentinel lymph, with melanoma is there any lymph node involvement? So when patients see us in our surgical oncology clinic, we ask them to come into a gown so we can do a skin exam and make sure that there's no satellite lesions or any other lesions that are missed, and that there's no evidence of any clinical lymphadenopathy or enlarged lymph nodes. If there's not, and patients have various characteristics of melanoma, we will often offer them a sentinel lymph node biopsy. A sentinel lymph node biopsy is the first lymph node where melanoma can spread to. Doesn't mean that melanoma is there, it simply means we have to biopsy those lymph nodes in order to make sure that there's not melanoma there. So for patients with melanomas that are 1 to 2 millimeters in thickness, basically everyone gets a sentinel lymph node biopsy. Unless they have some issues with their performance status, they might not be candidate for clinical trials. In some circumstances, they don't, but as a general rule for patients with 1 to 4 millimeter Breslow thick melanoma, I offer them a wide excision and a sentinel lymph node biopsy. Sometimes it gets a little bit more difficult for patients with thin melanomas. So patients with thin melanomas that are less than 8 millimeters generally don't get a sentinel lymph node biopsy. But if they have 0.8 millimeters to 1 millimeter in Breslow thickness, we sometimes will offer them a sentinel lymph node biopsy if they have other characteristics that are adverse, such as a high mitotic rate or ulceration, or if there's some concern about the deep margin being thicker than 0.8 millimeters. So that's a group of patients we will offer sentinel lymph node biopsies a little bit more selectively. For patients with thick melanomas, you know, this has become less controversial, but you know, about 8 or 9 years ago, it was a little questionable about should patients with thick melanomas greater than 4 millimeters get a sentinel lymph node biopsy? Would it provide prognostic information or not? But now we tend to offer sentinel lymph node biopsies for patients with 4 millimeters or greater thickness melanoma because there is some utility in this patient cohort. And the last important point that's important, last point that's important is the role of completion lymph node dissection. So sentinel lymph node biopsies are removing usually about 1 or 2 lymph nodes, sometimes a little bit more, sometimes 1, but it's just removing a small select number of lymph nodes where melanoma may spread to. And I have a cartoon for you to show you what that looks like. However, there was a time where patients that had positive sentinel lymph nodes ended up getting completion lymphadenectomies, which means we removed the entire lymph node basin within these patients as well too. But there was 2 major trials that happened in the last 5 years, one based out of North America, another one based out of Germany, where they randomized patients with positive sentinel nodes to removing all the rest of the lymph nodes, which aka completion lymphadenectomy, or just observing the group with the positive sentinel nodes. And at the end of the day, they found that there's no difference in the survival between both of those groups of patients. So that's pretty practice changing because there's been a lot of advances in melanoma in the last 10 years, a lot of which Yale has contributed based on systemic treatment options such as immunotherapy and some of these trials as well too, where you know, we are offering less surgery for patients because sometimes we want to help patients with surgery if we're going to help them, but we don't want to take patients through surgery if we put them into some unnecessary risk or unnecessary morbidity without providing much benefit. So these trials were very exciting in the surgical oncology community. So this is an example of what's called the lymphocentigraphy. So if you see us in our surgical oncology clinic, I tend to get a lymphocentigraphy on most of my patients, which is basically an X-ray of the lymph nodes, where the patient goes to the nuclear medicine suite and has an injection of what's called technetium and that travels to the sentinel lymph nodes. And we use that information in the operating room where we inject a blue dye called methylene blue, and that methylene blue travels to the sentinel lymph nodes. And using the technetium study and the methylene blue, we were able to make a small incision directly over the sentinel nodes and excise them. So that is what a sentinel lymph node biopsy is. And these are just some examples of sentinel lymph node biopsies in patients. Small incision for these. And the last few slides to round this out are just going to tell you a little bit more about survival. So the most important thing is the Breslow thickness, and this is what's called a Kaplan-Meier curve. And by what that means is on the y-axis here on the left is the melanoma-specific survival, and on the x-axis here are the years after the patient is diagnosed with melanoma. And as you see here in the purple, which is the top, these are patients with T1A tumors. This is from a recent study from the MD Anderson group, where patients have a thin melanoma have an excellent long-term survival. And as you advance and have a thicker melanoma, greater than 4 millimeters, the survival is not as good. So that is that's why the tumor thickness is important, and having a good dermatologist biopsy, such as Dr. Connors and his group, go a long way. The next important thing is if patients have positive sentinel lymph nodes, then the number of nodes sometimes can play a big difference. And what this shows is the more lymph nodes which are involved, the outcome is not the melanoma specific survival decreases. And that's basically what this busy slide shows. So in summary, so for melanoma, it is the deadliest type of skin cancer which exists. Prevention, early diagnosis, improve clinical outcomes. So we do reinforce to our patients to see the dermatologist, to perform self-body exams, avoid UV exposure, and remember the ABCDs or E's, because I think sometimes that'll be important for you when you examine a skin lesion on yourself or in a family member. The surgical treatment is the backbone to the management. So we summarize a wide margin resection, a sentinel lymph node biopsy, very selectively completion lymphadenectomies. I didn't show you some of the circumstances where it's useful, but there are some select circumstances. And and then this metastasectomy. What I mean by that is patients that have distant metastases of melanoma, there is a selective role where sometimes surgery can play a role. But this talk was given by, I'm speaking on behalf of surgical oncologists. If a medical oncologist, one of our medical oncologists gave you a talk, they would tell you about how great the immune checkpoint inhibitors are. So they have revolutionized the management for melanoma in the last 10 years. That class of drugs is just really changed the management. It's the most important group of cancer drugs that have been developed. And fortunately, it works very well for melanoma. So there's less of a role for that for us. And finally, tumor thickness, ulceration, and mitotic rate are the most important prognostic variables. We tried to show you that in the last couple of slides. And if the sentinel lymph node is positive, the prognosis is determined by the number of positive nodes, thickness, the mitotic rate, and ulceration. And that is it from my perspective here. And I'll hand it over to Dr. McGibbon.
That was excellent. Thank you, Dr. Kahn. Transfer, okay, excellent. Let me see if I can share my screen here. Okay, perfect. So again, I'm Dr. Bruce McGibbon, radiation oncologist at Greenwich, and I'm going to talk through really advances in radiation therapy for skin cancer, really particular to the non-melanoma cancers, especially the squamous and the basal cell. I would say that the main types of cancers that get referred to our clinic are really basal cell, squamous cell, and a kind of a lesser version or an earlier version of squamous cell called Bowen's disease or squamous cell carcinoma in situ. We definitely do see melanoma and Merkel cell carcinoma, and also a rare one called Kaposi sarcoma, and radiation can play a potential role in all of those. But to keep this talk a little more concise, we're going to stick to these non-melanoma versions. And of these ones, especially basal cell and squamous cell, about 70% of them seem to occur on the face. And of the ones on the face, at least a quarter, almost a third, are on the nose. Just something to, certainly the full skin exam is really full body, but certainly this is an area that we pay a lot of attention to in the clinic. Now, in terms of the management, now you've had that biopsy Dr. Connors was talking about, and it's confirmed you have basal squamous. How is this going to be managed? There are a bunch of options that are possible, from burning it or freezing it or certain topical chemotherapies, but I would say most of them are managed by some type of surgical removal. And one form that's perhaps the most popular these days is called Mohs surgery. And we don't have a Mohs surgeon here tonight, but it's a very nifty technique where you go to one-time visit for the procedure, and that surgeon really removes the tumor with very close margins, then looks at it under the microscope and tries to determine if they've really cleared all the cancer or not. And if not, they go right back and take a little bit more and keep looking at the microscope, going back and forth until they really feel they have cleared it. And this is a really good option for many of these early cancers, and especially the small ones, especially in an area where the surgical defect would not be too cosmetically challenging. It can be very nice. Obviously, what I do is not that, is radiation therapy, so I'll give you more detail on that. Radiation therapy has actually been used for skin cancers for well over a century now, but it's just not necessarily as widely known. Skin cancer is one of the very first things that radiation was even tried on to see if it could cure cancer. And a lot of it is done as what's called definitive, which is really where being done instead of surgery, one of these options. Sometimes for more advanced cases, we get called for post-operative, where surgery's not been able to clear it, or we feel like there's still a very high risk of it coming back, and so we're doing the surgery and doing radiation. Just get a sense of what the effectiveness is of these treatments. There was a study of it was retrospective, meaning that no one was randomized. It was just going back and looking at massive numbers of people to see what they got and how they did. And this was done and reported in 1989, so it gives you some perspective there. This is on basal cell cancers that have not been previously treated. And you can see the figures here down below it. At 5 years, the chance of keeping cancer from coming back were very high with really all the options. Now, there's, of course, selection bias here, because some of the ones treated with a curettage would have been very, very small. So it's a little hard to compare, but just getting a general sense of the numbers, you can see that everything's kind of in the 90%, and most surgery is arguably the highest here at 99. When we look further at comparing and look a little more at radiation, we can see that in our world, how much dose you can put in, how much energy you can put in, and how big the tumor is has a big impact on our chances of really getting rid of it and what the cosmetic result is going to be like. So in this trial by Lovett, for example, it's a little bit of a busy slide, we'll just kind of talk it through. You can see in this top, so first of all, just looking at local control, if you had a small tumor, less than a centimeter, chance with the basal cell getting rid of it really long term is 97%. As it gets bigger, it gets down in the 80s. You can see if you go a little bit to the right, in the SCC, that squamous cell cancer, that size effect is even more prominent. You really want to catch those squamous cells early. Early one, you're talking 91%, it dips into the 70s and 60s, you get really a large one. And the same thing goes, I guess it stands to reason on the cosmetic end. Most people who had radiation here were very happy with their result, either good or excellent. But it did relate to how big the tumor is. So you had people being thrilled with their cosmetic result when we were dealing with small tumor, but still mostly happy, but not as good with the bigger ones. And that, I think, stands to reason bigger cancers need more aggressive treatment, but it's all geared towards really finding these early and being treated early. There's one type of treatment that I'll show a little bit more detail later, which is newer, called skin brachytherapy. I'll show some pictures, but just to give a sense of some more current data than the 1980s on this. Here's a group that went back and looked at a couple hundred patients treated with Mohs and a couple hundred done with this brachytherapy. And it is relatively short follow-up, but I think it's still interesting. In about 3.5 years, it was 99 to 100% in both groups had control of this, and a very high percent were thrilled with their cosmetic result as well. show you just a little detail about how this works. So there are two basic styles of radiation therapy for skin cancer. You have X-rays and then what's called brachytherapy. So for X-rays, you have a machine. This machine that's in the middle here is called a linear accelerator. And the picture on the right shows someone who's this is actually a person being treated for a different type of cancer, something in the head and neck. But sometimes we need a mask or some other way of holding a patient on a table so they're still, and the X-rays are going to the spot that we're directing them to. And this can be done with X-rays that are similar to what's in a chest X-ray machine or a CAT scanner, or another version called electrons. Electrons are a cousin of X-rays that can be shot directly at a person that just doesn't penetrate as far. So X-rays will go right through you, so we have to be careful how we're shaping and angling them. Electrons will only go to a certain depth and then will stop. So it's especially effective for skin cancers, where of course we're mainly looking just to treat things that are very superficial. Brachytherapy is a different idea. And brachytherapy for skin, you have these bells or these applicators here, and they get placed directly on the spot. So in this picture on the lower right, this person's in a mask, and it's a lesion on the scalp. And this just rests gently on the skin. And there's a radioactive piece of metal called iridium that is kind of snakes through a catheter and goes into the bell. So it's never touching the person, but it's in that bell, and it's kind of shining the radiation down on the skin. And it's a different way of applying radiation. If we're using X-rays, we have a really broad range of what we can do in terms of the shape and size. There's really almost no limit on that. For brachytherapy, we just have these three different applicator sizes, and they are totally round, so and they have to be placed flat on the surface. So we're treating someone, let's say on the tip of the nose, where you can't quite put a flat applicator, it doesn't work out as well, but on the side of the nose, or the cheek, or forehead, or leg, or shoulder, it can work quite well. In terms of the number of treatments, I was talking about Mohs before. Mohs is more of a one-day procedure. It's one thing that's nice about it, but then it is a surgery, and sometimes it's healing from the wound and things like that. Radiation's a different idea. It's usually multiple visits. They're short visits, but multiple. And for let's say a medium-sized cancer, you can see there. This table shows a bunch of different options from 1 treatment to 3 to 5 to 8, all the way to 30 to 35. But the most common regimen is usually 20 sessions, and those are 15 minutes per session, done Monday to Friday. So it's usually a 4-week course for most things we do. And our machines operate from about 8 to 5, and so we find a 15-minute time slot that works for people, bring them in and just get that treatment and head home. And because they're X-rays, you can't feel anything on the table. So it's kind of in and out, and people go about their day using the same medications and everything. And our main side effect for most skin areas is what we call a skin reaction, which looks like a temporary sunburn. It's not a sunburn really, but it has that look to it. And we apply ointments, and that gets better, and the cancer shrinks down, and we get some healing in without having a defect there. So about 20 treatments would be the standard for X-rays. Brachytherapy is very different. It's actually only 6 treatments. And instead of being Monday to Friday, they get a little more spread out. They're usually 2 treatments per week. So in my clinic, I usually do them on Mondays and Thursdays. And they take, I'd say, closer to about a half-hour visit, although the actual time of each treatment is only about 4 or 5 minutes. The rest of the time is just getting set up in the room, making sure everything looks perfect. Just to give a couple quick examples of some outcomes here. Show some pictures. So hopefully the pictures aren't too off-putting here. Here's an example of a 9-year-old lady with a squamous cell cancer, quite large, over her wrist. And if you think about treatment options, this would be very difficult to do surgery on a 9-year-old lady. You can see her skin, like any 9-year-old, is quite thin. This would be a big defect, be hard to close. And so I was called to treat this one. And by the very last treatment, you can see that the cancer has disappeared, and you have this kind of sunburn patch over her wrist. And I saw her back at 3 months. There's a slight discoloration of the skin. Cancer's still gone, and very, very happy with the result. We get called a bunch of other before and after examples here, so we don't always get called for large things. Sometimes it's smaller things, maybe on the bridge of the nose, like the lady in the top left, or an eyelid. The more advanced one, like the tip of the nose on the top right, or the lip. Adjacent to eyes. There's a lot of facial ones here, but really these can be done all over the body, and because of where these things tend to pop up, then I have more pictures from the face, but it's common to treat on the leg, arm, shoulder, really anywhere for I'll give one other example of Bowen's disease. This is squamous cell carcinoma in situ. So this is an earlier, I guess, a less deep version of squamous cancer. This lady came to see me with this area, almost like a buildup of a plaque or scabbing, as it looked like on her foot. And you can see in this the left side that it really spread quite a bit. And she's in a very tricky situation. That to cut this out would have been a big defect on her foot. She had circulation issues to begin with, and would have been a very long healing, and kind of uncertain as to how to close that. And luckily for this, there is a radiation option which uses a lower dose of radiation than the full cancers. And the middle picture is how we immobilized her foot and ankle so we could make sure we're getting a consistent setup. And at 1 month, you see that we had a great outcome. It disappeared. She had just a very modest sunburn feeling on her foot, and was absolutely thrilled that we were able to manage it without surgery. So thank you for your time. That's it for my slides there. And let me see if I can get back up to our questions. And this is a good time. If you haven't typed anything in and you have a question, please do so. We have one question here, maybe be for Dr. Kahn, where the question was, I've lost the beat of it, but basically someone who had a melanoma some years ago, I think it said 7 years ago, at this point, what's the chance that it could still come back, or the risk of something popping up elsewhere, or how should they follow this up?
Repeat that again, Bruce.
Okay, I was going to direct this to Dr. Kahn, but if this is, if you have a melanoma about 7 years ago successfully treated and doesn't seem to be back, what's the chance that it could still come back now, and what kind of follow-up should you have there or for the rest of the body?
Got it. I thought you said Dr. Connors. Okay, so we sound similar, right? Connor. So so what we tell our patients is that they should. So I guess specifically this question is, so we tell our patients that for the first 5 years they should continue. For an early stage melanoma, they should see someone in our melanoma program. They should continue to see the dermatologist for the rest of their life. And the reason for that is, once an individual has a diagnosis of melanoma, we tell them they're 8 to 10-fold risk higher than the general population to develop melanoma again in their lifetime. That can be at the same location, or it could be a different tumor or in a different site. So the answer to the first question is it can come back 7 years out, but for an early stage melanoma, less common, more likely that a new lesion may develop. That's the reason for the dermatology follow-up. And if you have more advanced stage melanoma, there's a chance that melanomas can return at distant sites, depending on this initial stage of the tumor. I don't know, Dr. Connor, is that consistent with what you tell your patients too? Because we always ask our patients to see you for forever, but we stick with our oncology follow-up, basically 5 to 10 years, depending on the stage of the tumor.
Yes, it is consistent with what I recommend. The first couple of years after an invasive melanoma is diagnosed, I generally see the patients every 4 months. And after 2 years, we'll frequently go to every 6 months. But I see them indefinitely, and I have had considerable who many years later developed a second melanoma. I mean, I early in my practice, I had a young man who was a student at Dartmouth. He was an undergraduate. He had a melanoma on his anterior right shoulder. He moved away. He comes to see me now every 6 months. And 3 years ago, this is 25 years later, he had a second melanoma on his mid-back. So we look at them forever. They are frequently people who have had non-melanoma skin cancers. And you find plenty of them too in that same patient group. So we absolutely should follow them faithfully. Whether after the initial diagnosis, follow up at 3 or 4 or 6 months, that's a debated issue. But I think 4 months is reasonable initially, and then transitioning if things are going well, to 6 months and a couple of years.
Excellent.
And as a follow-up for, yes, what we do too for our surveillance is every 6 months for the first 2 to 3 years, and then annually thereafter up until year 5, unless they have more advanced disease. And if they have more advanced disease, we'll tighten that up to maybe 4 months or so. And that's usually our medical oncologists tend to follow those patients, because sometimes those patients are patients we're debating on, should they get immune checkpoint inhibitors? Should they be getting, are they qualifying for clinical trials? So that our medical oncologists tend to follow them a little bit more tightly than we do, just because they tend to see more of the advanced stage disease.
Excellent. I've got another question for Dr. Connors here. Do all skin cancers appear, or do skin cancers sometimes appear on areas not exposed to the skin?
Absolutely. Certainly the preponderance are on at least relatively exposed skin. As your slide demonstrated, there's a tremendous predilection for skin, non-melanoma skin cancer from the neck up, but there's no area on the skin where I haven't found, and I'm talking the bottom of the foot, the covered genital areas, and the hairy scalp, where I haven't found both melanoma and non-melanoma skin cancer. Melanoma is probably, of the 3 major, basal, squamous, and melanoma, have the highest percentage that occur on at least relatively covered skin. And it engendered years ago debate about, well, are they really sun-induced? Well, the epidemiology is overwhelmingly in favor of the sun being the major factor. I mentioned earlier, Australia. In America, Phoenix, Arizona has often led the country in the incidence of melanoma. So for the preponderance of melanomas, yes, it's sun, but there are exceptions, no question about it. I had a secretary for years, lovely lady, whose older brother died at a young age of a melanoma on his scalp, on a hairy scalp, no sun involved. So as you know, about 50% of melanomas have that CDKN2A mutation, and that can occur without any requirement for sun exposure. So undoubtedly, the proper skin exam for skin cancer looks at all the skin. That's what I limit that some with women. Men know, you come to me as a man, I'm going to see everything. With women, we make sure there are areas that I don't see are checked by the appropriate doctors. But there's no terrain on us that can't develop a skin cancer.
Excellent. One question I'll answer: do basal cell and squamous cell cancers turn into melanomas, especially if not treated early on? The answer is no. These are distinct entities. There may be some association between those who get basal cell squamous and those who get melanoma, but the one doesn't turn into the other. One other good question here was if Mohs is so successful, what are the scenarios when you would not offer Mohs for basal or squamous? I'll give my quick answer, and I'll let Dr. Connors expound more. But I think of the ones who come to us, I would say either it's because they've been through a bunch of surgical procedures like that, and they're kind of tired of being cut on, or they had some cosmetic outcomes that they really didn't like, and looking for a different option. Or it's something where it's large enough or in an area that we can already anticipate that it's really going to have an unfavorable cosmetic outcome, or it's obviously going to need radiation anyway afterwards, and we might as well just start with radiation and try to cure it without it. So that's kind of, I see it from my perspective. But Dr. Connors, any other kind of thoughts on when Mohs is not as optimal?
Well, I think we should give a little background for Mohs. Frederick Mohs was a dermatology surgeon at the University of Wisconsin 60 or so years ago, and he saw lots of farmers who had lots of difficult skin cancer, and he developed the method of treating them by using frozen sections while the patient waits. He initially impregnated the lesion with the zinc chloride paste, and then brought them back the next day, and it was akin to shaving a bad spot out of a banana, and every little shaving was taken and looked at under the microscope using frozen sections. That evolved into the current Mohs process, where there's no zinc chloride paste, and it's the fresh tissue technique. And it's an absolutely wonderful procedure for the right lesion. It's not meant for your routine basal or squamous cell. It's more complicated, it's more expensive. There is what I call Mohs addiction syndrome, where people who have had Mohs insist on Mohs for every basal or squamous they have, and it's really inappropriate. But it's a wonderful technique for difficult primary lesions or many recurrent lesions. An interesting area is it's used for pigmented lesions, and that pigmented lesions don't stain well with frozen section. So that's been an obstacle to using it for melanomas. But it's a wonderful technique. I think it's frequently, frankly, overused.
Excellent. One for Dr. Kahn here. The question is, what is the mitotic rate and how is it determined?
So the mitotic rate is basically how quickly the melanoma is growing under a microscope to a dermatopathologist. So after the dermatologist does a biopsy, they arrange for it to be sent to one of their dermatopathology colleagues, and they look to see how quickly the melanoma is growing under a microscope. And then that's a score that can be 0, and it can sometimes be in the double digits as well too. So it gives us a sense, it's a snapshot picture that they're looking at, but they can get a sense of how quickly a melanoma is growing just from looking at that mitotic rate. So.
Excellent. And then a question, I guess, for either of you two. So someone with 3 melanomas between 1994 and 2017 in different locations, being followed closely every 6 months, still trying to get a sense of what are the odds of having yet another melanoma?
It might be qualified by what type of skin the patient has, what kind of sun exposure, what kind of family history they have. Are they that dysplastic nevus syndrome where they have scores and scores of atypical moles? Obviously, no one can say definitively. I have had patients with up to 7 melanomas, but they are fair-skinned people with lots of moles and lots of past sun exposure. So the answer is we can't say for sure. Certainly that patient should be examined every 4 months, I think, rather than every 6 months. But that's my preference. But no one can answer definitively. But
Okay.
Clearly close surveillance is indicated. People who are just more prone to melanoma, both those with lots of moles. The point about the patient with lots of moles is, again, most melanomas begin de novo. They don't begin from an antecedent mole. On the other hand, people who have scores and scores of moles, both typical and atypical, are in fact more prone to melanoma. The dysplastic nevus is not a precursor of melanoma, but it's an indicator of an individual more apt to get melanoma. And so there's something about those people who make lots of mold, both benign and malignant, about their melanocytes. They're just inclined to proliferate, both in a benign and a malignant way. I mean, my wife's family, her sister, her cousin, her father, all of them melanomas. They're fair skinned, they're of Celtic background, and they spent summers on Martha's Vineyard. So whether it's primarily genetic or primarily environmental, I don't know, but that type of person certainly needs close surveillance. If there aren't any more questions, Bruce, I might ask you a couple.
Sure.
Am I interrupting another question? Go ahead.
No, there's a question. I think we talked about this, the increased melanoma risk. I think someone wanted to just repeat thoughts on what's the best sunscreen. You mind just, I guess, talking just a little more about the sunscreen?
That's a very good question. I can't say there's science that proves one is better than another. But as I said, the division in sunscreens is between organic and inorganic. The inorganic are zinc and titanium. And they're the ones that make you white, but they work right away. They're now much better cosmetically. In other words, you put on it takes 20 or 30 minutes, as I said, for the organic sunscreens to work. They don't pollute the water. They don't get into your bloodstream. I would favor a zinc or titanium sunscreen. It should be, again, an SPF that's 30 or higher, and it should say broad spectrum. The point about SPF is that, I guess I made the point, but people don't use the sunscreens nearly to the extent that the testers of sunscreens do. They use 2 milligrams per centimeter squared. We use about 1/3 or 1/4 of that typically. So there's a downside to sunscreens in that people are imbued with a false sense of security. They spray the sunscreen around their child and they've done their job. And they really aren't that protected. That's why clothing is so much better, so much better. I'm very delighted. There's a trend towards people wearing swim shirts now. It's wonderful because you can never get the sunscreen to your back the way you'd like, and the water clearly dilutes them. So long, the swim shirts, the golfers are wearing these sleeves on their arms, the big hat. Sunscreen is an additional thing, but it shouldn't be the central part of your sun protection strategies, actually. So I'm not saying don't use them, but understand they're imperfect and they don't give you the protection that clothing does.
Questions for me?
Yeah, a couple.
Sure.
What is the youngest age at which you would irradiate a basal or squamous cell? We've thought in dermatology 50 years of age. After that, okay, it used to be 60. It's now, I mean, there was always the concern, are you going to generate, if you irradiate a 45-year-old at 30, rather at 75, will he get a squamous cell because of your radiation? So
Yeah.
you have such an arbitrarily age-related schedule? I mean, is it?
Yeah, it's a good question. No, not really. I think, what we've seen is when you think of all the cancers that we treat and all the, I'd say, incidental skin dose, which is substantial, if you really sum it all up, we really see it's not that radiation never causes cancer. Clearly it does once in a great while, but skin cancer development years later has been very, very rare. The closest thing that I've really seen of that is still a less than 1% chance of angiosarcoma after breast treatment, where there's tremendous doses of skin there. But even that is quite rare. So I don't really have an arbitrary endpoint. I think it's just based on.
So if you had a 40-year-old attractive woman with a basal cell on her nose, you'd consider radiation?
I definitely would.
Interesting. Okay. We've also been of the mind, and you addressed it in your talk, but the extremities, particularly the lower legs, haven't done well with the radiation. Is that less true now with your technology?
We do have to be careful. I think that's something where I feel like surgeons and radiation oncologists struggle a little bit. It's all about the blood supply. So if you got a lesion, let's say over the shin bone.
Yes.
Everybody struggles there because it's just doesn't heal that well. It just takes a long time. And I think
that's right.
I think there that the key, there are a couple things that happen. Number one is, again, it's the size. What are we dealing with to begin with? Is there an ulcer to start? Because if someone's coming to me with an ulceration, it's going to take a really long time to heal. And then also, asking about diabetes and other more obvious, risks to blood vessel issues. But that said, I think, having a bigger excision over shin and the flaps and bracing, that can be very challenging also. So I think mainly I think there's still candidates, but the counseling I do in terms of, how long is this going to take to heal, and could you have persistent skin grafting? It is a different discussion. And same thing, I showed the lady with the lesion on the bottom of her foot. If that had been a regular squamous cancer, she would have been in a very difficult position, because the doses required that are double what are needed for the in situ, and you just really have tremendous issues on the foot. The area that we do really well in the foot and ankle, that I've seen quite a few of for reasons, are the Kaposi's sarcomas. For whatever reason, they tend to come up in the foot and ankle, and they respond really well to low doses of radiation, and versus the functional cosmetic output from surgery is not so hot. So it depends on the dose we're talking about, location, but yes, I think get close to the fingers and toes and over the shin is tricky. But if I'm treating over a calf, for example, usually does pretty well
Yeah.
there.
I would add to your presentation, Bruce, that radiation therapy for basal cells, squamous cells, particularly on the nose, it's underutilized,
I
frankly.
agree.
It's underutilized. I mean, the cosmetic result is superior. There's no surgery that approaches what you can do on a tip of the nose basal cell. And it's an option that's very valuable, very valuable. As you know, we've shared a number of patients, and they're delighted with the final result. Delighted.
Yeah, I'm really pleased that you mentioned that, because I completely agree. I think that there is, for what I've seen of certainly the centers that I've been to, or the academic centers, I should say, I think the education sometimes in some of the dermatology residencies and things is just lacking a little bit on what they talk about in terms of radiation. And all names aside, I've visited many dermatologists who really knew, you stand out as someone who's really quite knowledgeable about radiation. A lot of dermatologists really don't know much, or they know that it's maybe good for basal, but they had no idea it could be used for squamous, like literally no idea.
Oh.
And so, okay, well, yes, it can be, and talking it through. So there's, I love to talk to dermatologists and to surgeons, surgical oncologists in the community, to let them know that it's not the answer for everything, but it really is utilized for certain things.
It should, the good dermatologist should include it in the options. The good dermatologist should know the 5, 6, or 7 relevant possibilities. And for each patient, there's 1 or 2 that are maximal, that are appropriate.
Yep.
And radiation often is, and it's a wonderful technique. The thought in dermatology, I'll admit, used to be squamous cells don't do as well as basal cells. Is that no longer true in your experience?
I think it's true, but with an asterisk. It's really it's more size related. I was showing one of those slides. It's the bigger ones, but then everybody is struggling with
That's right.
Bigger ones, so it's so somehow that then seeped into a more general idea. It's lesser, and that's not true. And some of the squamous, we know some of the sensitivity, and perhaps some of it is an appreciation for what dose we should be using. Maybe some of the squamous, the bigger ones, should be using a little higher dose, and that's part of what's been underdone. Because certainly, the squamous cancers occur in the tonsil, the tongue, the cervix, all these ones. It's actually a fairly sensitive tumor type, and not that squamous of the skin is identical, but it's close enough. We do see a sensitivity there, and a lot of really good outcomes, like actually the lady with the large lesion over her wrist I showed. That was a large squamous cancer. Gone. So it is still effective, but everyone struggles a little more with those bigger squamous.
And I'm sorry to monopolize the discussion, but before you irradiate, you consider the histology as well. I mean, you know how varied basal cells are, and that micronodular or invasive are we used to call them more Fia-like basal cells.
Yeah.
Those are more difficult also for everyone.
More difficult, and I think that's where it's great to have a nice collaboration between dermatologists and patients, because then you talk through, the sense of what the depth and the width of the problem might be. So, Dr. Kahn was showing, some of the data about, how wide to create a margin depending on the size of the melanoma. But there's a similar concept in radiation, whether it's melanoma or squamous or basal, about how wide we should go and how deep we should go. Or even in certain cases, it's on something called perineural invasion, where it's tracking on nerves. We'd be actually going back and tracking a nerve even much deeper. And so, this is really where that collaboration is so important. And for example, that brachytherapy that I showed is wonderful for certain things. It can't go that deep. It must be a thin lesion. But luckily, we can treat whatever depth we want with electrons and X-rays. So it's it's having the various tools and the appreciation for how there is the variation that's really so important, and having that connection with the dermatologist to really talk it through. Let me just double check to see if there are any other questions here. Sorry, just scrolling through. I think those are the ones. I really appreciate everyone tuning in, and thank you to Dr. Connors and Dr. Kahn for joining us. We're really proud of the skin cancer care that's available throughout the Yale system and in the community in Greenwich more generally, and specifically with Dr. Connors and some of the other great people we work with. And certainly we're all, if you have further questions or need evaluation, we're all happy to help out and see people. And I just thank you all again for your time, and have a good rest of the evening.